we're going to talk about brain connections today, and there's going to be a lot of anatomy, but probably a slightly different kind of anatomy than you are used to so far. So as you already heard, we have the YouTube channel, that's the name, CNS Seminars. It's for everyone to join the discussions. We have journal clubs, specialized talks, debates coming up, as we just discussed. So you're more than welcome to join us for that. And you can be incognito or actually come on record. It's up to you. Now, I said that we're going to look at anatomy, and this is probably an image that you're quite familiar with. That's the typical image that we have when we talk about the brain. You see the surface of the brain, you see those gyri and sulci, and that's generally what we know about the anatomy of the brain. Now, this is not all of it, because the majority of it is actually hidden inside the brain. So what we can do is we can slice it up, we can look at the subcortical anatomy, and we can also look at the connection anatomy. Now, what you see here is about 17 years of me trying to understand the human brain. And I was very fortunate because I had the possibility to go into the morgue and study the brain in post-mortem dissections. And I became absolutely fascinated by the white matter connections that connect the cortical areas. Now, I was fortunate because the year I was born, a MR method was born as well, called diffusion imaging tractography. So by the time I was studying the brains, that method was advanced enough to be used in the living human brain. Now, because I got excited about white matter connections in post-mortem brains, I then started using white matter tractography in the living brain. Now, there's various advantages and disadvantages to both of these methods, but what you see here is a series of papers where we combined both of those methods. Now, what's important to know is that those are the only two methods that let you study white matter in the human brain. One post-mortem, one in vivo. There is no other method. There is other methods to study white matter, but that only applies to other species, for example. Like axonal tracing, where you can inject a tracer, you let it soak up, and then you sacrifice the animal to see where it went. Can't do that in humans. So these are the only two methods that we have to study the white matter. Now, how does it work? The method that I'm showing you here is called the Klingler postmortem dissection. It's called Klingler because Joseph Klingler in the 1930s in Switzerland developed or advanced the method of postmortem dissections. It was previously used, for example, by Burdag and Reil, but Klingler came up with a new technique to make the specimens last longer and also be better prepared for dissections. Just to give you an idea, in the early days, they just chucked the brains in a jar of brandy to preserve them. So those things have changed now. But what hasn't changed about this method is that it takes quite a long time to prepare the brains. So it's a repeated cycle of freezing the brain, thawing the brain, freezing the brain, thawing the brain. And ideally, this will last about 3 months. Now, this is just to get to the point where you have the brain in a, in a condition where you can actually perform the dissections. Now, the way you do the dissections, as you can see here, you prepare your brain in formaldehyde, and then you wash it, you clean it from all the arteries and the meninges, and then you, from here to here, you can suddenly see magic happened. And the magic is that you start carving away the gray matter. You peel it away, and that exposes the white matter underneath. Now, in order to do that, you really only need 3 things. You need a specimen and time. And these are the instruments that we use. And you can see there's nothing fancy, spatula, forceps. And everyone cuts them into shape. So that's really personal preference, how you want them to look. And then the microscope is optional. So you can use it. It's usually easier to do the dissections with the microscope, but you can also do it with the naked eye. And that's all you need, plus anatomical knowledge. But you get that on the way. Now, once you start peeling away the cortex, this is what you can see. You expose the white matter underneath. Now, this is now an image that we're not used to, right? The first one, if I had shown you the full lateral surface of the brain and asked you to label it, you could have probably come up with a couple of anatomical landmarks. If I ask you now, is there anything you recognize? It's hard now, right? So I'm going to put in a couple of pointers. We have our frontoparietal, occipital, and temporal lobes. What is still quite evident is the lateral fissure, or sylvian fissure, that separates the frontal and temporal areas. And then less prominent is the central sulcus, or the Rolandic fissure, that separates the frontal and the parietal lobe. So these are roughly the landmarks that we can still see. Now, in terms of the white matter, is this? So here you see those so-called U-shaped fibers, and they're nicely going from one gyrus here around a sulcus into the next gyrus. So they're really connecting neighboring gyri. They're very short connections. They bend very sharply, and that's why they're called U-shaped fibers. Now, these are in contrast to connections like this one here, which is the arcuate fasciculus. In comparison, you can see that the arcuate has a smooth, long trajectory in comparison to those very tight U-shaped connections. Now, that method is progressively peeling away the cortex and then the white matter. So the next step is to cut the arcuate fasciculus right here in the temporal lobe and see the white matter that's underneath there. So if we do that, this is what the image looks like now. So we still have our U-shaped connections here. This is the arcuate fasciculus, and as I said, we just cut it in the parietal lobe. On top of the arcuate fasciculus, we have the SLF, that is the superior longitudinal fasciculus, a frontoparietal connection. And when you cut away the arcuate here, you expose all of this white matter underneath. So this one here is the putamen. Then we have the internal capsule. Does anyone know which white matter connection is inside the internal capsule? Neurosurgeons love that one. I love how you had a chat and you're like, yeah, go. So it's the corticospinal tract. The corticospinal tract, depending on the level you're in, has a different name. So at this level, it's usually called the radiation of the internal capsule, but it actually goes all the way to the motor cortex and all the way down. And it bundles within the internal capsule. Then we have the inferior fronto-occipital fasciculus that goes all the way from the frontal lobe through the external extreme capsule here, which is a bottleneck area, and then it nicely fans out into the occipital lobe. Then here we have the uncinate. Uncinate means hook, and it has that name because it hooks the orbitofrontal to the anterior temporal. So all of these white matter connections, they might seem like they have strange names, but it's actually very descriptive. Arcuate, for example, this one, just means arching. It's the arching fasciculus. And that is because it's arching around the sylvian fissure that is now cut away here. Okay, so this is the arching fasciculus, this is the hook, and you can carry on and learn the names that way. But it's, once you see the pattern, it is quite descriptive and intuitive. Now, one thing I want to highlight here is the vertical occipital fasciculus. And I want to highlight it because you can see that from the IFOF, we have those long, smooth connections frontal occipital. And then here, the vertical occipital fasciculus is completely perpendicular to it. So you see that they're clearly distinct fiber connections because they have a very different orientation. Okay. Now that is also a matter of debate in the literature. It's like, how do we actually define if we're still in the same tract or if it is a different tract? So if you look at the IFOF in the uncinate, for example, right here, it's very hard to say, if not impossible, where one begins and the other ends. Okay. So the reason we say this is not the same connection is because the IFOF goes frontal and occipital, and the uncinate overlaps in the frontal lobe. It also overlaps somewhat here in the external extreme capsule, but then it has a different termination. So you use the termination and the trajectory of the white matter to define them anatomically. And that's also why in the literature we often see, we just had this discussion, systems or branches, 1, 2, 3, 4 sometimes. And that's because there's slightly different classifications of what constitutes a white matter connection that is one tract or two tract or different branches of the same tract. Okay. So, what do we need to know about Klingler dissections? It's obviously an invasive method, and that means it's a post-mortem method. So obviously you use it in specimens, not in living human brains, but also it's destructive because you peel away the cortex, you peel away the white matter. So if you make an error, there's no going back, right? You destroyed the specimen at that point. That also makes it very time consuming because before you cut, you have to think. And I remember when I started doing those white matter connection dissections, I was like, oh, I know my anatomy, I know my way around. I didn't. I had no idea. By the time I actually came to look at the true brain, the white matter wasn't color-coded. There was no labels around it. I was like, I don't know where to go now. So it does take quite some time, but it's a unique way of learning the anatomy. Once you find your way around in a postmortem brain, you definitely find your way around in an MR-based white matter dissection. It is obviously difficult to determine the cortical terminations because you peel away the cortex. There is now other means of doing it, and obviously we are technologically advanced these days, so you can take pictures at every step of the dissection and then digitally put it back together. And that way you can get an estimation of where the white matter was going in the cortex. There is some arguments that because you freeze and you thaw the brain repeatedly, you might actually introduce artifacts. Any idea why that might be? You can discuss it, send your colleague to speak.
Maybe because water is becoming bigger when it's frozen, and then when it's going to water again, you have something like a hole? Or?
Correct. So because the brain is filled with water, when you freeze the water, it expands. And what that might do is it might break some of the white matter connections, or it might push white matter together that isn't necessarily together in the normal condition of the brain. So this is why this freezing and thawing cycle might actually introduce artifacts.
Is it possible to know what the artifacts are and what like actual anatomy is? Is it like visible?
So now you're touching on a very important point. And the important point is that we don't have a gold standard. There's no way of knowing what the true actual anatomy looks like. Because post-mortem, we only have this method available, which has the limitations we just discussed. But then with imaging, most of the algorithms that we use are tailored to what we know from post-mortem anatomy, but also the algorithms infer where the white matter should be. So that's why I told you before that we're not actually looking at individual axonal structures, but we look at the diffusivity of water that is facilitated in one direction, hindered in another. And that's why the algorithm then assumes that this is where there should be a white matter connection. So we don't actually know the true anatomy. You can do axonal tracing, as I mentioned, but then you're in a different species. So now you're looking at, okay, how comparable is a monkey or rodent brain to a human brain? And that's why I said before, when you actually asked me that question, which method is the best? None of them. We have to combine them, piece them together like a research puzzle to actually answer those questions. Any other questions?
I have a question.
Sure.
Sorry. It's a different kind of question. Is this linear technique still commonly used?
It depends on how you define commonly, but it's still used, especially in the neurosurgical world. Because, as I said, it's an unparalleled way of learning the 3D white matter anatomy. But it's not commonly used in a sense that it's usually not as easy to get specimens to do the dissections. Now I know that it's slightly different in the Netherlands because people actually donate their brains to science more often. But generally speaking, it's very difficult to get brains in the first place for research, but then on top of that, they have to be prepared in the correct way to be able to do the dissections. And now we're looking at a very small amount of brains. What a lot of courses do, where they teach the method, rather than using human brains, they use sheep brains, for example. So you can prepare them in the same way. They're easier to get, but they're big enough so you can actually do dissections and see where you're going. So it is still commonly used, but it's not as widely used as it could be. Now, interestingly, and I just saw this recently on LinkedIn, I think it was, there's a company that is designing artificial brains to have the same properties than a postmortem specimen. So surgeons or any other profession who's interested can actually train on artificial brains having the same feeling and anatomy. Now the downside is that we're all going to work on the same brain. So you know the anatomy of one brain very well, but not necessarily of other brains. Any other question? Feel free to interrupt at any point, by the way. Okay, covered that one. Great. So now with those methods in mind, I'm sure you heard the term localizationism. No? Okay. So localizationism is the idea that one part of the brain does one function. And this goes back amongst some other patients to these three patients that I'm showing you here. Have you heard of Phineas Gage? Okay, so Phineas Gage, on your left, used to be a railroad worker in the US back in the day when they still had those big iron rods to fill them with explosive and get rid of stones to put down the tracks. Unfortunately for him, there was a day where he didn't pay attention. He filled his iron rod, it ignited, and this metal bar that you can see here shot through his skull, through his brain, and landed a couple of meters behind him. Now, legend has it that he got up, held his eye, and said, "I think I need to see a doctor," which tells you an important thing, and that is that his language was still intact. Right. Now, he, as you can see a little bit in this image, he damaged his frontal lobe, and his personality changed afterwards. So that is inhibition, executive functions, all of those functions were reported to have changed post-impact, and that placed inhibition, executive functions in the frontal lobe. So if we look at, sorry, I keep thinking this is a clicker. If we look at the skull, you can see here the exit wound that was left on the skull. So the iron rod came through here, through his eye, cracked the skull, and flew out here. Now, the second patient here is probably a little bit harder to see, but right here is a lesion. So that's an inferior frontal gyrus lesion. Do you know what the clinical presentation was? I think I heard it. Language, yeah. Better language, worse language, different language? Worse, correct. So with a stroke in the inferior frontal gyrus, this patient developed a language impairment to the point where he could only utter one syllable, which was ta, but his language comprehension was intact, just the articulation was impaired. And Nina Dronkers actually in 2007 published a beautiful paper where she went to Paris to scan the very brain. And it's still preserved in a museum, and here you see Nina, how she got it out of the jar and put it in a diaper to scan it in the MRI. Love that picture. So yeah, that's Broca's patients. He had 2 patients in this series, and you have the name of one and the brain of the other here. The other brain was the other patient. And that placed language articulation in the inferior frontal gyrus. Okay. Now the third one is Henri Gustave Molassin, better known as patient HM. Have you heard of patient HM? He's an interesting one. So he had epilepsy and was treated for his epilepsy by having a bilateral hippocampectomy. So they took out in both hemispheres the medial inferior temporal lobe and cut out his hippocampi. Any idea what happened?
Memory loss?
Memory loss? Do you know what kind of memory loss? So, the short term. So, he was able to remember events from his past, but he wasn't able to form new memories. So, for example, with his clinical carers, he would meet them every single day. Now, interestingly, he was able to learn procedural tasks. For example, playing the piano. That would get better day by day. So it's a different type of memory system. But that placed memory in the temporal lobe. So these are some of the famous cases that established our map of the brain, whereby one part of the brain is related to one function. And that is what we call localizationism. Now, for language, we have that too. And you've already seen Paul Broca's patients. So here we go. It's the patient we just saw. But we also have Karl Wernicke. So Karl Wernicke So, well, fair enough. I see those stroke patients with a lesion in the inferior frontal gyrus. They have articulation deficits, but I also see patients who have a language impairment, but a lesion in a different part of the brain. And his, which is now called Wernicke's area, part of the brain was the posterior temporal lobe. Now, patients with a lesion there would be able to articulate language, but what they wouldn't be able to do is to understand what they hear. Likewise, they would be able to talk fluently, but what they say was jargony or word salad. So they're completely fluent, but it didn't really make much sense. And you can go on YouTube, just put the names in, Wernicke and Broca aphasia, and you get videos of patients where you see that. Now, what's also important about Wernicke is that he postulated the first model of language in the brain by saying that we have a center for articulation in the inferior frontal gyrus, we have a center for comprehension in the posterior temporal, and they have to be connected. And they have to be connected for functions like repetition. If you want to repeat what you hear, you have to somehow send it from the posterior temporal to the inferior frontal. Now, interestingly enough, and I'm still trying to work out that puzzle, he showed his model of language in the right hemisphere. There's no explanation in the book. Still trying to work out if it didn't matter, if that was a mistake. We'll see. Anyways, so that's Broca and Wernicke, and then this fella is called Norman Geschwind. He was an American neurologist, and he added to the model of language the inferior parietal lobe. So here you have Broca's in the inferior frontal, Wernicke's posterior temporal, and here the A stands for angular gyrus in the inferior parietal lobe, and that is adding a center for integration, concepts, those kind of things. Because language is more than articulation and comprehension. You need to link it to what does it mean that this is a cup, or what is a pen. Like, you have to have those concepts of what words mean.
I thought those concepts were also kind of Wernicke's area.
Well, now we're coming back to the conundrum question. Yeah, so some say it's actually the anterior temporal, some say it's Wernicke's, some say it's inferior parietal. But I have a slide for you at the end. So this is what we know about language localizationism. Now, putting that all together, we came up with these areas and definitions of language in the brain. If you ask a random neuroscientist about what is language in the brain, you get Broca's area, you get Wernicke's, you get Geschwind's, and they're connected by the arcuate fasciculus. But there is a problem with that model. And the problem is that we are all different. Okay. Now, I have a definition of what I mean by variability because I got challenged once that we all have a different definition of what variability is. So I thought, just to be on the safe side, my definition is that our brains are different in their structure and their function, and that can even change across the lifespan. I hope that's not too controversial. Right, so what does that mean? So in neuroimaging, we often use template brains or brains in a standard space, and they look very pretty like this one. And areas that are alike between us are very crisp in those templates. So if we look at the basal ganglia, for example, they're super nicely defined. Areas that are more variable between us end up being a bit more blurry, like the temporal lobe here. And that is because in order to make the template, you have to overlay everyone into the same space, and you have to make them look alike. Now, if you have a different anatomy, it gets blurry because you can't align the boundaries of the anatomical features correctly. Okay. Now, while this doesn't look too dramatic on a template brain, an average brain, here's 2 examples of what that actually means. So what you see on the left here is the visual cortex in the left and the right hemisphere. So you already see a difference between left and right in the same person. But then also the difference between participant 1, 2, and 3, left and right, is quite dramatic.
What do the yellow and red colors mean?
It's the primary visual cortex and the associative visual. So here in 17 you have the calcarine sulcus and then V1 around it. So it's just a separation of the visual fields. Now on the right here you have the example of the motor cortex. Classically, when we try to identify the hand knob area, for example, so the part of the motor cortex that is important for moving your hand, we are often told to look for the inverted omega sign, which you can nicely see here. Now looking at a lot of different brains, you start to notice that not everyone has a nice omega sign, and it can be anything between a straight line or, I think this is called an epsilon, not sure. But yeah, it can be a straight line or you can have multiple bumps in it. So this is just 2 examples of how variable the gray matter can be. Now the white matter is no different.
Are these variations common, or is like most brains more of the same?
They're quite common. Same for the white matter. So without needing to know what all of these are, if we look at the arcuate fasciculus that you've already seen, we have this yellow segment here that connects the inferior parietus, so Geschwin's, with the temporal, roughly Wernicke's. And in participant 1, that connection is very thick and strong. As we go to participant 2, you suddenly see it's quite thin in participant 2 and then quite strong again in participant 3. Now, if we look at the hook, so the uncinate fasciculus connecting frontal and temporal, in the first participant you can hardly even see it. It's nearly entirely covered by the inferior frontooccipital fasciculus and the inferior longitudinal fasciculus here. But as we progressively go to the right, you can see that this connection becomes thicker and thicker. So there is a huge degree of variability in the white matter. So again, putting it together, the gray matter, you have a template brain, a classical standard brain, you have my brain, and a textbook brain, and you can see that in all 3 examples you can see Broca's, Geschwin's, Wernicke's, and they're in the same kind of part of the brain, but they're not exactly in the same location. Now, this is the variability that you can expect for the gray matter, and this variability is even exaggerated when we look at the white matter. So here you have an average arcuate fasciculus, which looks very pretty. And then in comparison, you have my tiny arcuate fasciculus, which looks still very pretty. But then in comparison to a textbook, for example, here the arcuate fasciculus is so different that it even has a different name. So here it's called the superior longitudinal fasciculus, which we discussed earlier is a frontoparietal connection. But here it goes all the way from nearly the entire frontal lobe to the parietal, into the occipital, and down into the temporal. So quite a degree of variability here. Now, this is the structural variability, but you can also see that in functional imaging. So what you have here is a classical fMRI task where the participant and the scanner needed to move the hand or the tongue, and then you see the activations. And here in yellow, you see where the motor cortex for the tongue is, and in green-blue on the top here, you see the hand. Now, what you can appreciate is that between those 3 people, you kind of get the same anatomy, whereby the hand is superior to the tongue. They're roughly the same size, but the exact location and extent of those activations is quite different between those 3 people. Now the same you can get when you do resting state fMRI. So resting state fMRI means, as the name suggests, participants can rest in the scanner, meaning they don't have to do a task. So you literally just put the participant in the scanner and just take a functional scan of their brain without them having to be involved, other than being awake. Which is fantastic because in a clinical setting, you often can't do an fMRI. If you have an acute stroke patient, there's no way you can get them to do funny tasks in the scanner, but you can potentially acquire a resting state fMRI data set, and studies have shown a good match between the 2. Now, in this study, Rubicon actually showed how the resting state networks differ between individual people. And again, you can see when you look at the blue and the yellow arrow that you see the same kind of networks in the same kind of part of the brain, but the exact location and extent varies between them. Now, what is quite interesting, she did a test-retest analysis and actually showed that you can replicate the same networks between day 1 and day 2. So it's not just random noise in the scanner, it's actually networks that we can replicate. And then bringing this back to language, what you see here is the variability in functional activations when fMRI studies probed phonology, semantics, or syntax, so word meaning or grammatical structures of sentences, for example. And you can appreciate from this figure here that the activations extend far beyond classical Broca's and Wernicke's area. Now, similarly, when you test patients, so this is a study in neurosurgical patients where they did TMS to elicit speech errors, so speech arrest. And what you see is, again, the percentages of patients who had this, speech errors when stimulated in this part of the brain. And you can see that there's quite a huge variability here. Again, in the numbers of how many people actually presented with speech errors, but also the distribution across the left hemisphere. Okay, so this is something to bear in mind. Now, why do we need tractography? How can tractography help us? Tractography can do many things. I'm going to show you 4 in more detail. The first one is that we can define new models of the brain. We can also use it to explain atypical patients. And by atypical, I mean they have a lesion in a part of the brain, but a clinical presentation that you wouldn't expect with it, or vice versa. We can also use it to systematically map the disconnection in clinical presentations, and we can use it to map variability. Now, the first one is the new models and why we actually need it. So here you see one of my stroke patients. You have a CT scan, a T1, a diffusion weighted imaging scan, T2, and a perfusion scan. Now, some of those contrasts let you identify easily that there is a stroke in the brain. For example, here you don't have to be a radiologist to know that this side of the brain looks very different to this side. And that probably the one with the hole is not the good side. Okay, it's quite intuitive. But on a CT here, for example, or even on the T1 to the untrained eye, it's a lot harder to see the lesion. Especially the lesion in the frontal lobe here, which you can, by contrast, see nicely on the diffusion and the perfusion image. So what you see here is that different imaging contrasts have a different sensitivity to brain lesions. Now, what all of them can show you is that the lesion extends into the white matter, right? Here is the gray matter, and then it goes deep into the white matter. Now, what none of these scans can show you is which white matter tract is impaired, or by how much. And that's where tractography comes in. So if we go back to our famous cases, now you know them all. and change our framework. So the first slide was exactly the same, but it said localizationism on top. Now it says associationism. So what my colleague Michel Thibaudet-Schrotten did here is he went back to get the original brains or skulls, whatever was available for each of those famous cases, and he reanalyzed them in a network framework. Pretty cool, right? Now, when you do that, what you see is that for Phineas Gage, his frontal lobe was in fact damaged by the iron rod that flew through. But what you can also see is that it was not a focal lesion. It actually had quite a vast impact on the white matter in the frontal lobe, but it also disconnected the frontal lobe from the temporal by damaging the uncinate fasciculus. Now, for Broca's patient, the lesion extended deep into the white matter. It's not just a cortical lesion, and we do get the arcuate fasciculus. We also get the superior longitudinal fasciculus, so the frontal parietal network, and we get other connections like the frontal Aslan tract here that connects the inferior frontal gyrus to the SMA, pre-SMA area. And then finally, for patient HM, we can see that the entire limbic network was disconnected by his surgical lesion. So it's the same patients, it's the same lesions, it's just a different way of looking at the damage that was caused by the lesion. Why do we need to do that? Well, here is our understanding of the visual and the auditory system, which, even without knowing what you look at, it looks pretty well understood, right? It's like every box here is a brain area, every line is a connection. We know what's going on in the visual and the auditory system. Now, when you look at textbooks for language, most of them still look like this, which in comparison looks like we might be missing something here. And that is because we can test the visual system and the auditory system in other species using other methods. We can't do the same with the language system. So we are confined to studying humans that speak, and you've now seen the history of how we came up with this classical model. Now, the rest of the talk, I'm going to show you what we have learned since we came up with this model. And basically, the classical model was Broca's, Wernicke's, and the arcuate in between. In the early 2000s, Marco Catani in London added the indirect segment, so a frontal parietal and parietal temporal segment to the model. And that was based on neuroimaging. And since then, all of these connections have been implicated as relevant for language functions using different methods. So they correlate with tractography, but they were also tested in surgical patients, for example, with direct cortical stimulation during awake surgeries to see if they elicit language errors. So all of these have now been, in one way or another, related to language, and this is probably a more comprehensive anatomy of how language in the brain should look like. Now, the atypical patients I mentioned, here's a patient with a tumor, as you can see, far away from the classical Broca's area that we can see here. Yet this patient presented with a Broca's aphasia, meaning comprehension. Good, bad? Good, correct answer. Articulation? Not so good. Correct. So this patient presented with a Broca-like aphasia, so articulation was impaired, comprehension was intact, but actually looking at the scan, the tumor is far away from Broca's area. Now, when you do the tractography, what you can see is that even though the tumor doesn't touch on Broca's area, the edema around the tumor is including the arcuate fasciculus, which can explain the presentation with a broca-like aphasia. Now, when we look at tumor patients, this is something we often see. So here we have the corticospinal tract. You see the internal capsule here, that nice boomerang shape it goes through. And here you have a tumor. Now, if you use an atlas, again, something we discussed earlier, if you use an atlas, the atlas will tell you that the corticospinal tract is right here. But because the tumor has a knock-on effect on the brain tissue, it actually pushed the corticospinal tract to the side, and now instead of finding it here, we find it over here. And this is why using an atlas in clinical patients is not a good idea. Do you guys want a quick break? Yeah? 15 minutes? Brilliant. If you want, I brought some props and books that I like to use, so feel free to come and have a look. Okay, any questions at this point that you didn't ask in the break yet? No? Okay, cool. So, atypical patients. Then the next thing I said is we can use it to map systematically the association between a disconnection of white matter and the clinical presentation. And I'm just going to talk you through an example here. So about the only part of the cortex that you can still see here is the insula. And some of you discovered the insula in the prop that I brought. So here we have the temporal lobe, frontal lobe, and if you go into the Sylvian fissure, you can expose the cortex underneath. And that's the insular cortex, or insula of Freil. And this is called the operculum, operculum meaning basically that it just covers the insula. So when people ask you how many lobes we have, frontal, parietal, occipital, temporal, insula. And then also limbic. Right, slight detour, coming back. In clinical notes, you can often read that a patient had a lesion to the insular cortex. Now, that can mean many different things. If a lesion in the insular cortex, for example, extends ventrally towards the temporal lobe, you might now disconnect connections that are important for visual processing. So in this case, the patient would present with a hemianopia or visual agnosia, for example. If the same lesion extends medially, we're now disconnecting the corticospinal tract. In that case, the patient will present with a hemiparesis or somatosensory deficit. If that same lesion, however, extends dorsally, we're now disconnecting the arcuate fasciculus, and now this insular lesion would lead to language deficits. So the take-home message here really is that the clinical presentation depends on the type of disconnection. And by using such an approach, we can systematically map the disconnection and the corresponding clinical symptoms. Now, so we can use it to map variability, and I've shown you individual examples of variability in the brain. What you see here is an overview. So if we go on the left here, the top panel, you see the gray matter of the brain. This is a medial view, this is a lateral view. And warmer colors here mean more variability. On the flip side, colder colors mean less variability. Now what you can see is that we have this gradient whereby deeper structures of the brain tend to be more alike, and we've seen that with the template earlier. If you remember, that was sharp in the middle and then blurry in the temporal lobe, for example, here. Now what you see at the bottom is the first ever map of white matter variability in the human brain. And again, we see this gradient whereby the deeper and older structures of the brain tend to be more alike, and more lateral connections tend to be more variable. And this is a nice way of quantifying how much variability there is in the group level. So this was done on a data set called the Human Connectome Project, which is a huge data set that was acquired in the US. President Obama, back in the days, launched the initiative. And it's a fantastic data set that came out of it with a multitude of different types of imaging. So we have functional, resting state, diffusion imaging, classical T1, T2 images, so that you can do a lot of analysis. And one of them that we did here was using the T1 images to look at the gray matter variability and the diffusion images to look at the white matter variability. But as I said, this is the group level. So this is on average across the population, how variable are different parts of the brain. Now, what I was interested in is to know how variable individual white matter connections are and what that means for cognition and behavior. So I sat down to do a systematic review to look at correlational studies between anatomical variability and cognitive variability, thinking that there surely aren't that many. And I sat down with a couple of friends and we're like, hey, this was beginning of lockdown, right? This is the early days. We're like, hey, how about we do this over the weekend? Just get all the studies from PubMed, look at them, write it up. Took us a year because there is 326 studies that we needed to go through and read. But it was worth it because there's a couple of things that we learned. And the first one that I want to highlight here is that most of what we know about the function of the white matter, we actually know from patients. So the majority of the studies was done in neurological patients, then psychiatric patients, and only 25% of the studies were done in healthy controls. Another thing that we learned is that some white matter connections are superstars in the literature, whilst others are a lot less prominently studied. Now, there is different reasons for that. One of them is that the anatomy of the corticospinal tract, for example, has been extremely well documented in the literature, whilst other connections like the accumbofrontal pathway are less well known. And another difference is that the corticospinal tract is quite a big, large, prominent connection, which you can easily visualize with low resolution data as well. So some of these connections, you actually need high resolution data to see them nicely. And then another thing is that within each tract, we can see that some of them are more prominent in some disciplines. So if we take the corticospinal tract, that is a very prominent connection to be studied in neurological and neurosurgical patients, but it's a lot less studied in healthy controls and psychiatric patients. And that profile changes depending on which tract you look at. Now, the other thing that we noticed is that there is no one tract, one function association. And I'm just going to zoom in for you. So when we look at the arcuate fasciculus, so far I introduced the arcuate as a language connection, and yes, the majority of studies actually do show correlations with language measures, but it also correlates with sleep, memory, executive functions, auditory attention, and motor functions. And when it is damaged, it actually correlates with clinical presentations. So what this has shown us is that studying the white matter is actually a reliable way of assessing variability in anatomy and its association with cognition. Now, bringing it back to the patient, the question is, does it matter? Right? We could just have variability in anatomy and variability in cognition, and it's fine, we're just different. But the question is, does it actually matter that we are different? So what we did here is a stroke study where I recruited patients in the acute stage. So I was doing the ward rounds in the morning to identify patients with language deficits, and then followed them up for a year. And what you see here is their language recovery 6 months after symptom onset. and that is plotted against the size of the arcuate fasciculus in the healthy right hemisphere. So all these patients had a lesion to the left side, they became aphasic, and that could be articulation, comprehension, or a mixture. And we looked at the arcuate in the healthy hemisphere. Now I'm highlighting 3 patients to you. Patient number 1 is down here. His recovery was not great 6 months after symptom onset, and when you look at the arcuate fasciculus, it's quite a thin connection in the right hemisphere. Patient number 2, you can see already did slightly better, and the connection is a little bit better in the right. Patient number 3 is in this blue box, and this blue box means that according to the test that we used, that patient is back to normal. So the blue box is a normal range of language function. Now when you spoke to the patient, you would still notice that there was some errors in form, but overall pretty good recovery. And you can see the arcuate is really thick and beautiful in the right hemisphere. Now what's remarkable about the study is that when you just look at clinical and demographical data, so clinical data being the severity scores, demographical data being age and sex and education, you can predict about 30% of the recovery. When you add in the anatomy, you can double that to nearly 60%, which is quite a good prediction. So it does matter that we are different looking at stroke patients. Now, we were also interested in the classical disconnection syndrome, which is conduction aphasia. You've seen it on the Wernicke slide. Broca's Wernicke's are connected by the arcuate. Those patients can articulate, they can understand, but what they can't do is repeat what they heard because the connection between the two is interrupted. Now, initially, that was the model. So you have the inferior frontal gyrus, you have the posterior temporal gyrus, you have the arcuate connecting it, and if you damage the arcuate, those patients can't repeat. Now, with the emergence of neuroimaging, CT scans and then later MRI, that shifted towards the parietal lobe because there was more and more patients in the literature who had a lesion to the parietal cortex and they weren't able to repeat, which would not fit the classical model, right? Because that has to be a deep white matter structure damage. So what we did in the study, we actually worked with Master Mesalam to look at his primary progressive aphasia patients, and we looked at the tractography of the arcuate and the morphometry of the language areas. Now, quite to our surprise, when we looked at the correlation between the arcuate fasciculus and repetition deficits, there was nothing. We're looking at a flat line here. Absolutely no correlation. When we looked at the indirect segment, so the green and the yellow together, we suddenly see a correlation appear. So if we split that by color, we can see that this correlation is slightly driven by the posterior segment. Now, in terms of the cortical areas, the only area that survived multiple comparison correction was actually the posterior supramarginal gyrus here at the end of the sylvian fissure, which is the parietal lobe. So this data then lets us conclude that we don't need the arcuate fasciculus as it was described in the literature. We just keep the indirect segment. And we proposed a new model. And the new model says that you can have a lesion anywhere within this network that can affect the white matter or the gray matter, and you will end up with repetition deficits. Now, obviously, depending whether your lesion is affecting the anterior or the posterior or both, you might have different flavors of repetition deficits, but you will end up with repetition deficits. Now, where do we go from here? Now we know we're different. Now you know it matters. where do we go? So the first thing is that we should always challenge what we think we know. And this brings us back to the discussion we had earlier about the methods. Do we know what we know, and does it hold up when we use a different method? So it's always good to go back and challenge yourself, and this was one of my journeys in Bordeaux. I was actually working at the Center Broca, because Broca came from the Bordeaux region, and everything is called Broca in Bordeaux. But whilst I was there, this discussion became apparent if we should rename the center, because not everything he did in his research was considered as good by today's standards. So we actually went back and revisited the debate to see if we should or shouldn't rename the building. I'm not going to give it away. You can draw your own conclusions whether we should do it. But what this really highlighted to me is that we just took it for granted that Broca was a prominent, important person in our field, without knowing the full picture behind it. So it's always good to go back and challenge yourself. And this is obviously an anecdotal story, but this also applies to the data, as you've seen earlier, by just going with the lesion or the disconnection approach, for example, where you have the same patient, the same lesion, but a very different conclusion of the underlying anatomy of a clinical presentation. Now, another thing that we should do is we should combine our methods. We have the most amazing tools available to us, but we tend to use them in isolation. People like me use tractography most of the time. Other people use fMRI all the time. But really the power comes from combining methods in a multimodal approach. And this is one study where we did it. So we had a fMRI data set of 144 people in Bordeaux who did a language task in the scanner. We took those fMRI scans, did the classical statistics on it to get the T-stat maps, and then averaged and thresholded the maps as you do with functional imaging. Now, on the other side here, we started with 1,333 stroke lesions that my colleague used to create disconnection pattern maps, meaning that he used the lesion, put it into a software to see which white matter connections were affected, and then you get a map of all the white matter damaged by a given lesion. Now, there is some principal component analysis to identify the 46 components that explain most of the variance in the data, and that's the second data set that we used. So fMRI, lesion, and disconnection maps. And then we ran some regression analysis over it to come out with maps that look like this. So what you have on the top is the fMRI activation for reading in the brain. Classical average map. Then we identified the white matter that is essential for reading. And here you get the exnus area in the posterior middle frontal gyrus, and you've seen this one before, the vertical occipital fasciculus. And then we also used this approach to come up with a classical lesion that would cause a reading deficit in the brain. And this is the lesion that explains most of the variance in the data that we've seen. And you can see it's quite an extensive lesion here on exnus area, inferior parietal, posterior temporal visual areas. So this is the power of combining different imaging modalities that we have available to us. Now, another way forward is to think differently. And you've basically seen the story of this figure. So the early days, we had a modular approach to language in the brain, Broca's, Geschwin's, Wernicke's, articulation, concepts, and comprehension. We have seen that the story is more complex than that. Here you have the hierarchical model where repetition falls under, for example, where you begin with understanding and then you send it either via the long segments, that was the red one, or the indirect segment through the parietal lobe to your center for articulation. And we've seen shortcomings with that model as well. So what we argued in this paper was that probably we have to rely on an integrative model. Integrative here meaning that language is a function that emerges through the interaction between areas. Language is not located in one part of the brain. It's through the interaction that emerges as a function. And this is what we're currently studying to see if this model holds up using different modalities, different data. It's undergoing thorough testing at the moment. But the idea here really is that if you ask the orchestra, for example, where's the song? They can't tell you where the song is because it's nowhere. The song emerges through the timed interaction of the instruments. And that's a bit like language in the brain. Language isn't located in one part of the brain. It emerges because all these different parts of the brain interact and work together. Now, another way forward is that we want to make predictions. So right now, when a patient comes into the clinic with a stroke, we can't really tell them where they will be in a year's time. We can make rough estimates based on demographical data, clinical data. If we're lucky, we have some good imaging data. But it's pretty much a guess of where that patient would land. Now, in this paper, Leah Talozzi did a wonderful thing where she took individual brain patients, so again, those 1,333 patients. She took the lesions that you can see in black here, and then put in a software to get those maps of disconnection. So what you see here is all the white matter that was affected by that lesion and was disconnected. She then created, using machine learning algorithm, the space of where those disconnection patterns land. And here, patients with a similar pattern clustered together, and patients with different patterns are separated. So if we look at it here, for example, we have a occipital lesion in the right, and all of these patients here will have an occipital lesion in the right hemisphere. Whereas over here, for example, we have a parietal lobe left lesion. Now, whilst it's nice to see that patients cluster together if they have the same kind of disconnection, the power really comes in the next step, because we can use the location in the space to predict the long-term outcome. So for those patients, we had data from the acute stage at 2 weeks, 3 months, and 1 year. And what you can do using this machine learning algorithm is to use the acute imaging to see where an individual patient falls within the space. And then based on the data in your data set, you can predict, given the location of this patient in the space, where they will be in a year's time. And she managed to have a fantastic prediction of about 80%, which is pretty good. Thanks to our reviewers, we also had to compare our method with every other method in the literature, which was good. A lot of work for Leah. But it actually showed that if you account for the pattern of disconnection in the white matter, you actually have the strongest prediction, or the most reliable prediction of where that patient will be in a year's time. So that's quite exciting work that is just about to come out. Right, so there is a beautiful paper in the special issue in Science by Peter Stern that is called "No Neuron is an Island," which I thought was a beautiful title. And in the paper he writes that the brain is so much more than just its constituent cells. Each neuron in the brain connects with thousands of other neurons, but instead of a cacophony of connections, we have a synchronized symphony, which I think is a beautiful way of summarizing what I've just told you for the last hour and a half. And going forward, I want you to be like a neuron. Go out there, connect, make it happen, and especially connect between clinical research and other stakeholders, so to say, in the field, and find your own connections. Go out there, see how you can change neurosciences, either in the clinical world, in the research world, or very different. So we, for example, have it's called Neuroscience Alliance, which is a NGO, where we try to bring neuroscience methods and tools into low to middle income countries. And rather than just sending information there, we actually go there to help set it up, give workshops how to use it. But there's many other ways of how you can build connections around the world and make it happen. So find your niche and go out there and be like a neuron with thousands of connections. This is just a little info for you because we talked about this. This is the Wernicke conundrum, which was a recent debate in the journal Brain. And I didn't include it in the presentation tonight, but we actually had a journal club on the 9th of January where we go into a bit more detail in what the conundrum is, how to solve it, and why the current literature may or may not have solved the conundrum. Right, with that, I thank you for your attention. I happily take more questions.